All right, in this LLSA 2021 article, we're doing identification, management, and transition of care for patients with opiate use disorder in the emergency department by Dubber et al. And we've got Matt DeLaney hooking us up.
Yeah, so Dubber et al. Are basically giving us kind of an overview of the problems we have with opioid use disorder, which I think if you have worked more than one shift in the ED, a lot of this is a nice reminder, a good refresher. They start out by saying, hey, look, in the emergency department, we are likely not the main cause of the problem of opioid use disorder. They say that we actually prescribe less than 5% of all opioid prescriptions in the US. Despite the fact that we're not the problem, they say, obviously we deal with the complications from the opioid crisis. We've seen this 200% increase in overdose deaths since the 2000s. And when we look at who dies from overdoses, about 66% of patients have an overdose that involves an opioid. So obviously it's a big problem, even though we didn't start the problem. They break down their recommendations. There are 4 different recommendations. First, they say we should consider targeted screening for opiate use disorder. Second is we should treat acute withdrawals in the ED. Third is consider or initiate medication-assisted therapy, and they call it MAT. And fourth is we need to focus on this transition of patients from the ED to the community. So they walk us through the nuts and bolts of the recommendations. They up front say we should screen for opioid use disorders, and then they kind of break down the tools we have. And the bottom line is that none of them are great. So the idea would be that we target patients based on our perceived risk that they have opioid use disorder. There are a couple of tools they call self-reporting tools. So I ask the patient the questions, do you abuse drugs? And they have to self-report. The SOAP, the SOAPP/R is a tool that's out there that I'm not super familiar with. Studies have shown that it's fairly accurate in terms of picking up cases of opioid use disorder, but it's lengthy. It's 24 questions. And then there's another one, the National Institute on Drug Abuse, Modified Alcohol, Smoking, and Substance Involvement Screening. This has been out there. It's been studied, not really an ideal tool in the emergency department.
You know, Matt, that's the same thing. I have never used either of those. I usually just kind of go with my clinical gestalt and history. It is lengthy on the SOAP. There are some questions in there, though, that I think can be helpful in terms of what I will add to kind of my history taking to help me identify these patients maybe a little more reliably.
Yeah, it's not a no-use tool, but it's a little bit clunky. So those are the self-reporting tools. The next thing they push for is these prescription drug monitoring programs. There's a ton of state-to-state variability. I'll tell you, the one in Alabama is not super slick. And the reason we have these is there's some weak association in the literature between the presence of a prescription drug monitoring program and a reduction in opioid overdose deaths. The problem is that when they've studied these prescription drug monitoring programs in isolation, they don't really reliably pick out the patients who are struggling with an opioid use disorder. The authors of this paper say, hey, maybe if you pair these monitoring programs with the self-report programs, they'll be more accurate, but that's really speculative. They don't have data to necessarily back that up. One of the things they say that's really interesting is that there's an overall low quality, really, they describe it as poor evidence to support the idea that we universally screen everybody. So we should look at patients if we think they have an enhanced risk of having an opioid use disorder. That's when we should look for things like the prescription drug monitoring program, not for everybody that walks in off the street.
One thing that I do, Matt, is whenever I'm prescribing an opiate, I will kind of automatically check that box. Okay, let me just check, in the system for the state of California, which is, clunky but not horrible. And it's kind of like a little reminder. I have found some instances where I've picked up on some misuse just because I have it as an automatic kind of thing I do anytime I'm sending a patient home with opiates.
Yeah, a lot of these tools are good ideas that may work, but it just hasn't been borne out in the literature yet. So I agree. I use it in a similar way. The second thing the authors emphasize is that we should treat acute opioid withdrawals in the ED. Now, they base this recommendation off this idea that if we have a patient and they're having acute withdrawals and we treat them, that somehow this will impact and improve their future compliance. There's not a lot of evidence to back up that recommendation. They say, hey, potentially doing this will reduce indirect morbidity and mortality kind of down the road for these patients. I think the reason we should treat acute opioid withdrawals is because it's the right thing to do. These patients feel miserable. We just unfortunately don't have a lot of evidence to tell us how effective this is going forward for the patients. When it comes to managing these patients, they talk about the clinical opiate withdrawal score, and that's the COWS score. I think a lot of us are using this. It's an 11-item scale. And what we do is we run the patient's subjective and objective symptoms through this scale, and we can figure out kind of where are you on the spectrum of withdrawing. And that lets us identify the patients who need to be treated and also can guide our treatment decisions. When we talk about treating these patients, they go through several different medications we can use. So the first one is buprenorphine. Remember, it's a partial mu-opioid receptor agonist, and it has strong affinity for that receptor. The issue here is that if we give this to patients who are not actually in withdrawal, we can precipitate withdrawal. So we really need to get that COWS score, make sure they're actually withdrawing. And in terms of how do we treat patients, so the starting dose is 2 to 4 milligrams sublingual, and then we watch the patient for about 60 to 90 minutes. You can titrate up in 2 to 4 milligram doses. And these authors say the initial induction dose is 8 to 24 milligrams daily. There's a lot of variability in the literature in terms of what the right starting dose is. Somewhere in that range is probably okay for most patients. Now, often buprenorphine is paired with naloxone. The goal here is to deter abuse. So that naloxone, if you take it sublingually, has no impact on the patient, but if it's melted down and injected, it blocks that mu-opioid agonist effect. And that seems to be fairly reliable. One of the nice things about buprenorphine is it's safe to use in pregnancy. Now, these authors say if you're going to use buprenorphine in pregnancy, don't use it with the naloxone. Don't use this paired combo. They say that that's because there's this theoretical risk that the naloxone could get into the baby's circulation and cause issues for the baby. There are other studies that have come out that actually question this. And there are a couple of more recent studies that say, hey, really the important thing is we treat pregnant patients. And if you want to use a paired agent, that's okay. But these authors say the safest, most conservative route is to stick with just buprenorphine.
Matt, that's a new medication that we started using in the past 2 years, and I like it because as opposed to having to kind of put together a cocktail to treat withdrawal, I now have my first go-to, and the dosing really is assisted by the pharmacist. Pharmacy's been on board in terms of trying to help us start the dosing based on the patient's COWS score and their history. I do have one question I want to clarify on that. When you're saying paired with naloxone, that's for the patients that we're sending home on buprenorphine, or are we pairing it with naloxone in the active withdrawal phase in the emergency department?
So that's a good question. It doesn't really matter, right? So it's just a different formulation. So in my system, I can order buprenorphine/naloxone, and that's one pill that comes and taped sublingually. And I can also order just buprenorphine. So it doesn't really matter. Buprenorphine is the active agent we want to make sure that they're getting.
So I'm not adding naloxone. It's like you said, it's a combo pill, which I wasn't aware of. Awesome.
It's a combo pill. It's right there. Other agents that we can use, methadone is out there. I don't use this often in the emergency department. It's a long-acting mu receptor agonist. Typically, the way that we'll use this in the ED is just to continue a current prescription. So if a patient comes in and they're in an MVC and they're on methadone, those are the patients where I might say, hey, I don't want you to withdraw, so we're going to continue this. The dosing, these authors recommend just ask the patient, hey, what dose do you take? And then continue that dose. Again, this is very seldomly prescribed outside of the emergency department. It is safe during pregnancy, so you may have a pregnant patient come in who's taking methadone. And the keys, if you have a patient who's taking methadone, or if you're going to reach for this agent, would be monitor the QT, and you want to avoid this in patients who have liver disease. Clonidine is one of these things, and Matt, you were talking about this. This used to be my go-to, this and a bunch of other kind of over-the-counter agents to try to manage these patients. It's an alpha-2 adrenergic agonist. It's actually been used off-label to manage withdrawals, and the dose is 0.1 milligrams PO Q6 hours for a maximum dose of 0.4 milligrams total over a 24-hour period. And these authors say that this works best in combination with other agents. In terms of the literature tells us this basically doesn't work. Patients will tell you it's better than nothing, but it isn't great. But I think if you're in a situation where you're throwing everything at the patient, it may make sense to look and see, hey, does clonidine have a role here?
You know, Matt, you just gave us 3 choices of medications to treat withdrawal. My question is, can we combine them? Can you do like buprenorphine or the buprenorphine naloxone combo and then add the methadone or the clonidine if the buprenorphine's not enough? Or does it even help to make it as a combo?
There's not any real evidence to answer that question. I don't know of anybody that's combining a buprenorphine with a methadone. That's you're just kind of really flogging the mu receptor into submission at that point. I think the idea of adding in clonidine makes a little more sense. You're just hitting a different receptor. But the good thing is that buprenorphine seems to work so well that it's really unusual to get a patient who is maxed out on buprenorphine and where you're looking for something else to help these patients. Buprenorphine is actually so effective, it kind of leads to the third recommendation from these authors, and that's consider medication-assisted therapy in the ED. And so the basic idea here is, can we start you on medication that will then continue after you leave to help, number 1, get you off of opioids, and number 2, kind of keep you in recovery. And the recommendations are, we want to evaluate the patients, and we need to ensure and document that they meet the criteria for opioid use disorder. So this is not the person who said, I took a Lortab last night because I just wanted to party. We really want to have a good idea that this is actually a patient struggling with addiction. And then the authors say, look, there are a lot of benefits to medication-assisted therapy. They say there's a decreased risk of subsequent overdose, there's less ED use and hospitalizations, there's increased engagement with recovery programs. Now, all of those things have been shown to be true in studies. All of those studies are small and have major limitations. So I think that medication-assisted therapy is a great idea. I think that the evidence is slowly starting to catch up with the fact that we've seen this work. And so low quality of evidence, but the studies we have do seem promising. These authors say the medication of choice for medication-assisted therapy is going to be buprenorphine. And then one of the big tips here is if you have a patient and you look at them and you say, I think you have opioid use disorder, and I'm going to start you on medication-assisted therapy. Every single patient needs to go home with a naloxone rescue kit if they're being discharged. And typically this is a naloxone nasal spray. So if you're in a shop where you're doing medication-assisted therapy, this needs to be part of your action plan for patients. You go home with a prescription, you go home with a naloxone rescue kit in hand. And that's really designed in case you relapse. This is the way somebody can save your life, or if you're hanging out with somebody and they overdose, putting naloxone in people's hands likely will improve outcomes for patients. Again, the big pearl here is for all the things we do for patients who have opioid use disorder, the thing that's most likely to save a life down the road is making sure we prescribe and ideally give them a naloxone rescue kit. When it comes to medication-assisted therapy, one of the issues has been, how do we prescribe buprenorphine? So there's a legislation, the Data 2000, and that's where this X-license waiver came out. And the issue with this is that per the X-license waiver, to prescribe buprenorphine, we have to have an 8-hour training program. And this is kind of an add-on merit badge to your DEA registration. Now, the workaround is there's this 72-hour rule. And what that means is that if you haven't gone to your 8-hour training, you don't have an X-waiver as a clinician, you can dispense but not prescribe buprenorphine out of the emergency department without the waiver. Now, the semantics here are really important. That means that they have to come back. So I don't just give them a stack of buprenorphine, but typically I give them a dose, they go do something else. They come back to the emergency department for the next dose, and I dispense yet another dose. Now, I can't prescribe anything, but I can get the patients the medication. And this kind of 72-hour rule lets us dispense, but again, not prescribe both buprenorphine and methadone. And what they say is if we're going to do this, whether we're using the X-waiver or whether we're using this kind of 72-hour rule, patients need to have, quote, a streamlined plan for follow-up, which is a great thing to say, but in reality, I think it's a lot harder for a lot of us to ensure takes place.
Yeah, this is some of the speed bumps on buprenorphine. I mean, it's a great medication. And what I think really we're going to have some political changes that will get rid of both probably that X-waiver, or at least the long 8-hour training, and also the 72-hour rule as we kind of move forward and realize, like, look, this is a good medication. It's safe. So hopefully it's not forever with those speed bumps.
Yeah, the final thing the authors emphasize is we need to really focus on the transition from the ED back to the community. A lot of this stuff seems like pie in the sky, but really when you think about how do we improve outcomes for patients with opioid use disorder, I think if you have these systems or we can work towards these systems, it's going to be good for patients. So when they talk about components of comprehensive treatment, number one is medical assisted therapy. Number two is psychological intervention. Number three is social support and case management. That makes sense. We see that you have an issue. We're going to start you on medicine, but there's more to the story. The authors emphasize, with not a ton of evidence to back up this emphasis, that the time from when the patient leaves the emergency department and follows up is high risk. And they talk about it's really important we do linkage to treatment. So a lot of places are trying to start 72-hour bridge clinics. I can dispense this medication for a couple of days, but I need a clinic to pick you up. So can we bridge you from what I'm doing to what the clinic will then do? And they talk about a warm handoff, which is the idea that if I'm treating a patient, I actually talk to another clinician and can ensure that this care is going to continue after they leave the ED. Again, it's a nice idea that unfortunately a lot of us just don't have available to us. And then they finally say consider non-opioid medications for withdrawal symptoms. So if patients have diarrhea, something like loperamide. But really, they finish out this article by saying, look at the whole picture, not just the specific things we do in the emergency department.
This is Hippo Education.